And he literally has helped kids go from being blind to be able to see. I could tell you so many stories, but I don't want to take up his time. So thank you so much for taking up your Saturday to come and talk for us.
Good morning to all of you. And a special thanks to Ruben and to Jan and to the Alyssa Phillips Foundation for allowing me to address you. I'm honored and I'm grateful because in my interactions with so many of you, I'm always impressed by the faith and hope you display in your child and the charity that is so evident in the labor and the time you put in to making them more fully alive. And my task is to help you make them more visually alive. And I'm going to address 3 common misconceptions that pertain specifically to children with cerebral palsy. One is that many or the majority are cortically blind. The other misconception is that their eye wandering or misalignment and gaze deficits are merely cosmetic and not functional disorders, and that repairing those is merely cosmetic because the brain damage precludes adequate repair. And then the third misconception is that many children with cerebral palsy won't wear glasses, and blurred vision is not acceptable. There all are alternative therapies that we can use to restore sharp vision. The dark spaces that you see at the back of the brain here are the occipital horns and lateral ventricle, and this is the visual part of the brain. And a more accurate term for CVI is really cerebral visual impairment, not cortical visual impairment. Why? Because cerebral entails the white matter, which underlies that gray cortical mantle of the cortex. And the majority of children with cerebral palsy do not have cortical damage. What they have is white matter damage, which is the feathery, bright lesions that you see on the lateral walls of each ventricle, the classic periventricular leukomalacia lesion. Visual fibers progress this region, as do motor fibers that descend to the limbs, which is why you have a combination of gross motor dysfunction and gaze dysfunction, and occasionally impairment of sensory vision. Cerebral visual impairment is a useful wastebasket term that you know many schools, state agencies, and therapists want to use. It's a useful label because it's often the magic ticket that gets you funding for therapy. And so I'm not opposed to putting in the diagnosis CVI if I think it will be helpful to the parents or the therapists. But it's important for you to understand that a minority of children with cerebral palsy actually have a major component of cerebral visual impairment. What does that mean? Cerebral visual impairment is low acuity, okay, about 5 lines worse than that lowest line on the Snellen chart, combined with neuroimaging evidence or ultrasound evidence of damage to the posterior part of the brain, which is the visual brain, in conjunction with the fact that you cannot explain the visual deficit with simpler, on a simpler basis, an optic neuropathy or a refractive error, a focal length error of the eye, or damage to the retina, prematurity, or some other cause. It's important that your child's vision be tested accurately, and that requires skill and time, but it is nevertheless an achievable goal. It can be achieved by standard verbal responses if your child is capable of that. If not, then there is a technique called preferential looking, which can be performed, in which the child's gaze is used to discern the resolution of carpets that they can see, and from that you can equate to a 20/20 or 20/30 or 20/50 or 2100 vision. If they're not capable of doing the preferential looking gaze shifting, then there's even another technique called the spatial sweep evoked potential test, which does not require any of those, no verbal response and no steady gaze. And yet it can quantitatively define for the school and for therapists and for agencies and for forums. What is the actual acuity that my child sees? And the center to which you take your child needs to be capable of doing it, so the test is available. What age to have the child's vision tested? In infancy, first, if there's significant developmental delay or obvious motor dysfunction, or evidence from the medical record of brain damage, sometime in infancy, then again in the preschool years, and then again in grade school and in the teenage years. Even if disorders are not detected or brought to medical attention in the visual system until grade school or teenage years, there still are therapies to which the system is amenable. Yes, the earlier you get the child, the easier the repair, but you should not despair if there's a delayed diagnosis. Most parents get very nervous when they bring their child because they think we need to do very sophisticated testing that's going to require great cooperation on the part of the child, and that's not true. If you have a skilled team, you can extract the kind of quantitative information, accurate information you need, even in the most uncooperative children. Occasionally, this will require different parts of the exam, 1 or 2 minutes of gentle restraint. If there's something strikingly abnormal that we don't think that we can adequately define with the child awake, then a brief exam under anesthesia can be performed, and that's something we do all the time. It's a very safe thing to do, and you can do very precise measurements if warranted. The questions that we want you to be able to answer are these. Does your child detect? How small an object can your child detect? Are they attracted to things that don't make noise or are kind of bright? How far away do they identify you? How do they respond in a crowded versus a simple scene? Do they pick out targets? Do the eyes wander? Do they track well? What's the eye contact like? And then assessment of their depth perception. How do they do, particularly with changes in elevation? An important component of the exam is that you remain calm. As all of you know, your child can sense your anxiety much better than often you can. And so they pick up on all your cues as to how nervous you are. So just be calm and detached, and that will have a very favorable influence on the overall tenor of the exam. And all approaches and different components of the exam are first to win the child's cooperation. But if you can't win the child's cooperation to get the information you need, then you go to the gentle restraint, which is big guys win. Don't be reluctant to bring multiple family members to the exam. I actually like that because they can answer questions that you haven't thought of. It's another set of ears to think of and hear what we've had to say. You don't have to have all your questions there for us. You can always email us. You can always call back. There'll be clarifications you'll seek. And that's just part of the overall assessment. The way that we test visual acuity is with simple pictures, matching symbols to begin with. If the child can say house, car, duck, then we'll do that. That gives you an acuity every bit as precise as the standard adult Snellen letters that you are all used to having being tested by. Then, as I said, there's there's the forced preferential looking method, also called the acuity card procedure, which is a card that has 2 different targets on it of different resolution. And children are naturally attracted to sharper images. And so the images get finer and finer and finer resolution until you reach the child's threshold. It requires no verbal response, just an automatic gaze response. And from that, we can discern a quantitative level of acuity. And as I said, if the child can't cooperate for that, then we go to an electronic method in which EEG-like electrodes are placed on the back of the scalp. A pattern is shown on the screen, and it sweeps from fat bars to thin bars over an epoch of about 10 seconds. The corresponding brain activity is measured. And when the signal of the visual part of the brain reaches the noise level of background activity in the brain, the computer can very precisely measure the threshold level of acuity in that child. So it's equivalent to doing a letter chart, except it's automatic and it's computerized. And this gives an example. This is a paper that we published with Jan a while back in the British Journal of Ophthalmology on measuring visual acuity in children with cerebral palsy. What I want you to appreciate is that along the y-axis there, okay, is visual acuity. In the top graph is optotype acuity, that is letters. The bottom graph is the spatial sweep acuity. This is a group of children in which we can test both letters and the spatial sweep, and there was a very good correspondence. So CDI, also in the old termed cortical blindness, is uncommon in cerebral palsy. And if you don't take the time to tease apart the kids' real visual deficits, then you get lumped into this wastebasket term of cerebral cortical blindness. But most of the visual impairments in these children are not cortical blindness, and in particular, many of them relate to gaze deficits. And the chief feature of this tends to be a gaze apraxia. So remember that an apraxia, whether you're dealing with the arm or the leg or the eyes, is a disfacility in carrying out a specific task. So it's an incompetence. Whenever any of us are learning a sport or a musical instrument, we in a sense have an apraxia. All right? We do it very clumsily. It takes us a lot of time, and we're inaccurate. And that's what an apraxia is. Given enough time and given enough effort, the child can complete the task, but they don't do it in an automatic and skillful fashion the way you and I do. And there are two chief features of this that all of you see in children who have gaze apraxias. One common complaint is they don't make good eye contact. Right? How do you know that I'm intelligent and polite and I care about you and I'm listening to you? Because when you talk to me, I look you in the eyes. But if I had a feature of gaze apraxia called fixation and persistence, then I can't do that. While I'm talking, my eyes are wandering all over the place, in addition to probably my head. And from that, you can incorrectly intuit, oh, the child is disinterested, or the child is distracted, or more commonly, the child is unintelligent, or the child doesn't like this task, and none of those things are true. The point is that the child, because of the fixation and persistence, has to muster their will to fixate a target, whereas you and I do that automatically. The gaze apraxia beyond fixation and persistence has to do with the accuracy and the speed of moving your eyes and smoothly following targets. And these gaze deficits are common because the anatomical drawing on the left in those red dotted lines and the MRI image on the right show you the shrinkage of the white matter fibers around the occipital horns of those lateral ventricles. And this is where the gaze fibers traverse from the occipital lobe forward to the motor parts of the brain to control gaze. The point being that gaze circuits are all often damaged in the presence of PVL. So here's a child with cerebral palsy and a typical gaze apraxia. So the task is very simple. Just follow the target. His vertical gaze apraxia is more severe than his horizontal. So his attempt to initiate, particularly upward eye movements, is very much impaired. And we're exacerbating the problem, Mom is, by holding his head. Because what he wants to do, and he's learned to do, is facilitate these inaccurate gaze shifts with head movement and to compensate with head movement. So you free his head, and his deficit of eye initiation and tracking improves. And the task in this girl, this classic fixation and persistence, is simply look at the camera. So the entire time I'm coaching her, look at the camera. So all she has to do is make eye contact with the camera. And she is mustering every ounce of her will to do that. And yet, despite that, her eyes are continually flicking off target. Gaze apraxias and fixation and persistence can be measured very precisely by a number of methods. An infrared video digital goggle method. There's also a non-contact infrared camera method that we use for children who won't tolerate this when they won't. And this shows you what you've seen in the previous videos. So a saccade is a rapid and accurate eye movement. And the graphs show that normal children initiate this type of eye movement with a very short latency, about a fifth of a second, 200 milliseconds. Whereas this population of CP children took 3 times as long to get their eyes going to a new target. And with their head free, they did better than with the head restrained. So with the head restrained, it took them over a full second to initiate a change in gaze. How does this practically impact the child beyond the issue of social eye contact? Well, it has big implications because the gaze apraxia's greatest impact in learning is in reading. What many of you don't appreciate is the fact that when you read a page of print, you're typically making 3 very precise eye movements at a latency of about a fifth of a second as you read each sentence, okay? So you precisely gauge the jump so that the penumbra of your visual fixation encompasses about 2.5 words. So you're going 2.5 words, then 2.5 words, then 2.5 words, and you automatically splice at the edges of the penumbra as you shift your gaze. But it requires that you make these precise eye movements. So they're horizontal, and then in typewriter fashion, you go back to the left, and you have this thing in precise vertical register as well. The child with gaze apraxia will make eye movement number 1. Then in an attempt to read that line, eye movement number 2, but they've jumped too far. So they've missed the syntax of the sentence, right? Then they'll make also a vertically inaccurate eye movement, so now they're offline and really confused. And I'm commonly asked, what visual therapy do you have for this? And we tried different things that were ineffective in terms of just getting the kids to exercise their eyes in a more precise way. Why? Because unlike gross motor function, where you have to have physical therapy all the time to keep things in tune, right, and to build strength, if you think about it, you're exercising your eyes all the time. Even when you're sitting perfectly still, you're exercising your eyes all the time, which is why the muscle fibers are designed so differently than skeletal muscle. To approach this problem from a different perspective, what we're doing is developing a combined gaze-locking and print moving software that hopefully will be able to be used on something like an iPad. So it locks onto the child's gaze, and then rather than requiring the child to make precise eye movements, the script is actually moved into the center of that child's gaze. And then you can tune it for the individual child in terms of the tempo and the size of the print envelope that you're going to present in succession. I think ultimately that may be a better approach. Most of you parents have said all of these things. This is from another paper that we wrote with Jan on visual motor deficits in children with cerebral palsy. And the kids are variously described as visually inattentive, unable to see or follow, makes no eye contact, looks away, looks over, or uses only peripheral vision. In particular, uses only peripheral vision. Why? Well, think about it. The brain damage, as I showed you to those white matter tracks, forces the child to scaffold around the deficit. You and I, if we're at the table, and I want to say something to her, I say it. But if there's a damage, a lesion here between she and I, then I've got to pass the message all the way around the table. And that's the analogy for the child with cerebral palsy carrying out this motoric gaze function. Then they have to muster all of their will. Unlike you and I, where we have all these wonderful parallel circuits that operate automatically, the child with a significant gaze apraxia and cerebral palsy can focus on one task at a time. So if you say to me, pick up the glass, I look at the glass and I pick it up. You say this to a child with GMFCS3 and gaze apraxia, their choice is, okay, I can do everything I can to look at that glass, or I can do everything I can to reach for that glass, right? And so then you say, well, they're looking away and they're using peripheral vision. That's not something they're doing deliberately. That's something that they must do because they got to put down one phone and pick up the other in order to get that task accomplished. This shows you the corticospinal motor tracks, which are those red tracks descending through the internal capsule and down into the spinal cord. And I want you to appreciate that the gaze control centers are all around this region, which is why gaze deficits and vision deficits are so common. In addition to the gaze apraxia, as many of you know, the child can have strabismus, which is the pathologic term for eye misalignment, causing conflicting visual images and double vision, and it impairs the child's depth perception. The classic one is for the eyes to converge inappropriately and constantly, and that's called esotropia, though the child's eyes may also deviate outward, called exotropia. The brain is forced to shut off an image from the deviating eye. The child may alternate fixation and alternate the suppression of one eye or the other. And it impairs their depth perception, causes visual confusion and discomfort. And it's very prevalent. The repair of that is relatively simple. It requires a 25-minute outpatient eye muscle surgery that is not painful. You put numbing medicine in the eye socket while you do it. You make a small incision and go behind the eye. You don't have to take the eye out of the socket. And then you lengthen or shorten the appropriate muscles. And when the child is healed, it's difficult to detect that they've had any operation. You can travel the same day. There's not physical therapy and a hospital stay associated with this. It may require more than one operation. But the message that you need to understand is that repairing binocular vision in children with cerebral palsy is desirable and possible, and it's not simply a cosmetic defect. And this can be performed at any age, but the younger the better, and the more robust the repair in very young children. Another important component of the testing is to test the focal length of the eye, since many children with cerebral palsy will have extreme focal length errors, either with one eye or both eyes, which can blur the vision. And this can be nearsightedness or farsightedness or astigmatism, which was a situation in which the eye shape looked more like a football than a basketball. If the focal length error is substantial, according to these numbers, then you would, as a first go, prescribe glasses. The majority of children with cerebral palsy are not suitable candidates for contact lenses because of their blepharospasm and aversion to anything approaching their eyes. Attempts to fit contact lenses can emotionally and physically exhaust the parents. And then, as you know, many kids with cerebral palsy are aversive to any head appliance, so they may not keep glasses on. And if they will keep glasses on, often the lenses, even though they sharpen the image, they distort things because of their thickness. And particularly in a child with head movement and eye movement deficits, if you think about the child's always looking over the glasses or at the edge of the glasses, or the glasses can get dislodged. So glasses therapy, though important in many children, can be ineffective for a substantial number, which is why you go to alternative methods of treatment. And the alternative methods are really an adaptation of adult LASIK to pediatrics, or implantation of contact lenses inside the front chamber of the eye. And the excimer laser ablates, pulverizes, or removes tissue so it reshapes the cornea of the eye to get rid of nearsightedness or farsightedness. That's effective within a certain range. There's a certain magnitude of farsightedness or nearsightedness that you have to stay within because it's too much for the laser to correct. In those children, thankfully, we have the alternative method, which is implantable contact lenses, which can correct even the most extreme refractive errors, though it does require that you make an incision and go inside the eye with an implant. So in a typical pediatric LASIK type operation that we do, it takes 20 minutes to treat both eyes. The child's brought into the room, anesthetized, there are electronic measurements made. Then the child's wheeled under the computerized laser, which is programmed with their refractive error or focal length error, and you target refraction. And then they're treated, their little bandage contact lenses are put on the eye, which stay in for a few days just to promote comfort and healing. Then we put goggles on, or elbow restraints for a few days. But it's proven to be a very safe and effective method of correcting their blur. If the magnitude of the error exceeds that you can correct with laser, then I go to an alternative method, which is the implantable contact lens. There's one that clips to the pupil or iris tissue and sits just in front of the pupil. And this is an example of a child treated that way. And there's an alternative one called the intraocular columnar lens that slips behind the pupil. So I'll use either technique depending upon which is more suitable for the child. And again, this is outpatient surgery. It's not painful. It doesn't require an intense post-op course of therapy. Typical outcomes from this kind of refractive surgery are shown here. So, concentrating on the right graft, this is comparing children who wouldn't wear glasses either pre-op or post-op. And what we were able to achieve is a 2-log unit or 100-fold gain in the child's uncorrected visual acuity. Uncorrected meaning the child walks around without needing to wear glasses or contacts. So the deficits to the vision system that occur in cerebral palsy, many of them are not exotic. The strabismus and the refractive errors are the same kinds of things you see in normal children, and neurologically normal children, but they're more prevalent. And then all CP kids deserve a thorough eye exam. And don't settle for the fact that the child can't be tested. Or more commonly, there's a bigotry that says, well, blurred vision, your child won't wear glasses, their eyes are wandering, and they have crossed eyes. That's good enough for a child with CP. And what they're telling you is it's good enough for a child with low IQ with no potential. That's what they're telling you. And we can't believe that. I mean, we've shown in our studies that you can remarkably improve the vision if you go at it in a logical and precise fashion. I want to leave you with this. Cerebral vision impairment is a useful term to apply to the chart to get the kid therapy. But the majority of kids don't have a major component of CVI. And the gaze-aid praxis' biggest impact is it makes reading more laborious. Teachers need to understand that. Parents need to understand that. Attempt to make adaptations with larger print or more spaced print. Try different techniques. There's not a magic formula for each kid. It's an experimental approach with each child. And then make sure that the visual system has been thoroughly tested so that you know what deficits can be corrected, what deficits can't be corrected. How can you improve the child's overall life? Thank you.